Dr. Zulfikar was kind enough to come and be here with us today in between her clinics. So we are going to expedite this as best we can, let her start out. And then we do have a case, I think, for the second half. But we're going to start with introductions real quick. Dr. Zulfikar, do you want to start introductions?
Yes, good morning, everybody. My name is Rafi. I'm one of the assistant professors in pulmonary critical care and sleep medicine at WVU. I'm one of the relatively newer faculties. I trained here, and I'm happy to be a part of ECHO project and be giving a small talk today.
Excellent, thank you. All right, and Pocahontas Memorial, you guys want to introduce yourselves?
Yeah, I'm Dean Gunner. I'm the director of the department here, and I got Hannibal Motti. He's my medical director and the ER director here this morning. He's ex-WVU we recruited. Yeah.
Excellent. Thank you both so much for being here. Lisa, do you want to introduce yourself?
Yes, I'm Lisa Emery at Grace Ann Dorney Pulmonary Rehab and New River Health Association Black Lung Clinic. I'm a respiratory therapist.
Excellent. Thank you so much. All right, and Dr. Doyle? Oh, we can't hear you. I'm sorry, Dr. Doyle, we can't hear you. We'll work on it. Eric, do you want to introduce yourself? Eric, did you want to introduce yourself? Sorry. Oh, and you're muted.
Sorry, yep. Eric Stockton with the Dorney Koppel Foundation in Washington, D.C.
Excellent, thank you. All right, and Dr. Sela?
Elson Sela, I'm the pulmonologist at Preston Memorial Hospital and the consulting pulmonologist for the Appalachian Pulmonary Health Project.
Perfect, thank you so much. All right, Sam Giordano, do you want to introduce yourself?
I'm Sam, excuse me, I'm Sam Giordano. I'm chairman of the U.S. COPD Coalition and a retired registered respiratory therapist in Dallas, Texas.
Perfect, thank you so much. All right, and Krista Mestel, do you want to introduce yourself?
Good morning, Krista Mestel. I'm the program coordinator for the Black Lung Clinics program at HRSA.
Excellent, thank you so much. We have a phone number ending in 3422.
Yes, that's Diana Carpenter with the model with Pennsylvania. Good morning, everyone.
Excellent. Good morning, Diana. Let's see, we have somebody named Drew.
Hi, good morning. This is Drew Harris. I'm a pulmonologist at the University of Virginia, and I also am the medical director of the Black Lung program at Stone Mountain.
Perfect. Thank you for joining today. All right, and we have somebody, I'm so sorry, it's ERBE. And you are muted. Do you want to introduce yourself? That's okay. If you have any challenges introducing yourself, please feel free to chat us, and we can make sure we record your attendance. Dr. Doyle, do you want to try again? We can't hear you. I'm sorry. I don't know what it is. But everybody, Dr. Doyle's here. All right, and I'm Caitlin Ettinger with Project ECHO. So Dr. Zulfikar, I'm going to share your slides, and we'll just get started.
My goal with making this presentation was essentially to keep in mind the varied audience we have most of the times when we do these discussions and case discussions. Obviously, I couldn't touch upon all the components of interventional pulmonology, but in my mind, I'm trying to think, what would a non-pulmonologist want to know? Some of the basics of interventional pulmonology. I did not go through any of the detailed studies that validated these procedures. For some, there are good studies, and for some, there are not. So I essentially made a presentation that I would want if I was not a pulmonologist and, say, a primary care provider, for example. Oh, I'm not able to move forward there. Thank you. So objectives for what is interventional pulmonology, what are the components, and what are the uses? I think uses is what, was kind of going to be my main focus for today. Next slide. Interventional pulmonology is a subspecialty within pulmonology, which we know focuses mainly on non-invasive endoscopic procedures. ERS and ATS finally defined it, so to speak. It was introduced first time in 1995, and the definition, I'm not able to control my own graphics here. The definition that was officially put out there was the art and science of medicine as related to performance of diagnostic and invasive therapeutic procedures that require additional training and expertise beyond a standard pulmonary medicine training program. This definition itself tells us that interventional pulmonology is not something that every and any pulmonary fellowship is able to provide. However, I have to point out that over the years, over the span of last 25 years, there has been a big shift. There are procedures that were considered to be interventional pulmonology, and people needed to go through specific training to actually be able to do those procedures. And over the years, they have trickled into regular pulmonary and critical care fellowship. But there are certain procedures, even till date, that need specifically a year of extra training for people to get certified. Next slide, please. I have two slides on history, just briefly. The gentleman in the left top corner is Chevalier Jackson, first rigid bronchoscopy done in the United States. The gentleman in the right lower corner is Gustav Killian, German laryngologist. If anyone's interested in history and has ever read, there is a beautiful paper in ATS specifically talking about the history of bronchoscopy. And these two giants are the ones who led the way, so to speak, for bronchoscopy to come into the mainstream of medical practice. Next slide. I couldn't go forward without mentioning Dr. Shiketo Ikeda. He was the first physician, thoracic surgeon from Japan, who introduced flexible bronchoscopy in the 20th century. And that since then has been the standard of care in terms of doing any bronchoscopic procedures. We very rarely use a rigid bronchoscope, for example. Next slide, please. Some of the components of IP, again, as I said, I have not been able to touch on every single component, but I picked up some of the ones that we here at WVU are able to provide, and there are some that we don't, but I thought it would be worth mentioning because, again, in my mind, I'm thinking, what are the questions that the patients, come with to the clinic? So bronchoscopy with endobronchial ultrasound, from here on referred to as EBUS, navigational bronchoscopy. Use of forceps basket cryoprobe. This was at some point considered a part of interventional, but to be honest, at this point in time, forceps basket and cryo are something considered to be a part of conventional pulmonary practice, and any pulmonologist is most of the times during fellowship trained in using these tools. Airway stenting, again, an advanced airway procedure. Endobronchial valve placements, and bronchial thermoplasty. What is not listed on this list is, for example, medical thoracoscopy or pleuroscopy, rigid bronchoscopy. These are some of the other additional things that are used. Endobronchial brachytherapy. These are all other additional components of IP. Unfortunately, we wouldn't be able to go over most of the ones that I mentioned at the end. Next slide, please. Indications for advanced IP procedures and their utility. I think the first and foremost, what we have seen where they're being used, diagnosis and staging of suspected lung cancer. I think endobronchial ultrasound and bronchoscopy has revolutionized non-invasive methods of staging lung cancer. Diagnosis of granulomatous diseases, again, through non-invasive needle biopsy, TBNA. Foreign body retrieval, again, currently part of regular pulmonary fellowship, but used to be a part of advanced pulmonary training. Opening airway by stenting the airway, debulking of endobronchial tumors. Improving functional capacity by endobronchial valve placement, and lung biopsy in interstitial lung disease by using cryoprobe, which is by the technique of freezing. I put question mark in front of that is because this this indication for cryo is still being explored. I think they're using this a lot more in Europe, but not so much in the United States. Next slide, please. So I have a case here, 65-year-old Caucasian male, lifetime smoker, 1 to 2 pack per day, evaluated by PCP for lung cancer screening and went through the lung cancer screening CT scan. He was found to have a lung nodule with some hilar and mediastinal adenopathy. What would be the next best step? I do have an image, if Caitlin would press the next button for me. So there is the CT scan image that shows an enlarged station 7 or subcarinal lymph node. If I were the primary care physician, I would like to know what would be the next thing that I should think of. Well, first would be, let's see if we need to pan scan this patient, PET scan obviously, but what would be the next best step in terms of diagnosing this patient? Next slide, please. And that's where the next picture here shows us the PET scan that shows a station 4, which is a little higher up above the subcarinal, station 4 node that is PET positive. Now, this is a very classic case where we see a patient in the clinic, we see their imaging, we see really enlarged lymph nodes with very significant high-risk history, and we know that our next step is going to be endobronchial ultrasound. Next step, please. So EBUS bronch, where we do regular bronchoscopy and something called endobronchial ultrasound. The picture here denotes a bronchoscope with its end that shows an ultrasound probe. This is a convex probe. What we essentially do is, when we are in the airway, we try to make the contact between the airway and the probe and try to look at the lymph nodes that were being shown on the CT scan at station 7 subcarinal, station 4 higher up, and then we further go into station 10 and even 11 at times. Next slide, please. I have to mention Dr. Wong here. Copen Wong in 1978 from Johns Hopkins came up with a technique called the TBNA, transbronchial needle aspiration. Now, when Dr. Wong came up with that technique, it was being done blindly based on your knowledge of anatomy. You go inside the airway, you reach the carina, you try to locate where you think subcarinal lymph node is, and you just blindly needle it and get the sample that way. With that background and adding ultrasound technology to that is what EBUS brings to the diagnostic armamentarium. Next slide, please. This, I think, is an interesting picture. On the left right hand of the screen, we see an EBUS probe, an ultrasound probe here that has a balloon on it that is inflated. Now, this is the convex probe where ultrasound is projected to the soft tissue. The balloon essentially helps us make better contact. And this is the working channel from where the needle goes in once we have a visualization of the lymph node. So here is what it looks like when we're doing an EBUS. We see a lymph node. And once we know we are in the right spot, we don't have a vessel on our way, usually the needle comes out at 1 o'clock. Once the needle is inside the lymph node, we actually take at least 20 passes, and we, at each station, say for example, subcarinal lymph node, we do 20 passes each time, and we do 4 such passes. Most of the studies have shown that if you do a minimal of 4 passes, your diagnostic yield is close to 85%. Next slide, please. The reason I put this slide here is because I wanted to make it, I wanted to impress on the fact that how important it is that whenever we do these advanced procedures, how it changes a patient's staging, hence their treatment plan. One thing we have to remember is if I see a CT scan that has a sub-centimeter lymph node, the yield on EBUS drastically decreases. It has to be at least a centimeter or more. The bigger the lymph node, obviously, the higher the yield. The lymph nodes, for example, if this red mark here is the lung nodule. Now, right around that lung nodule, station 10 and 11, that's the hilar lymph nodes, still keep it at N1 stage. As soon as we go to subcarinal lymph nodes, and if they're positive, it automatically goes to N2, and ipsilateral station 4 is also N2. As soon as we move to the contralateral side, we are already talking about an N3 disease. So at each station where we make a stop and take a needle biopsy, we are trying to stage the patient at the same time. So what we essentially do traditionally is when we are inside the airway, we start with the contralateral station 4. We start by looking at it to see if it is big enough for biopsy. If it is small, we can't do a safe biopsy. It was small on the CT scan. We go to the subcarinal, or we go to the ipsilateral 4, and then we go to the subcarinal, and then at the end we go towards the 10 and the 11, so that we start from the highest stage and then sample down. Next slide, please. Navigational bronch, I see it as an extension of endobronchial ultrasound and bronchoscopy. What this adds essentially is, for example, on this picture here, the green dot is not a lymph node, it's a lung nodule. So there is a lung nodule that is quite distal in the airway. With a regular bronchoscope or an endobronchial ultrasound scope, you cannot get to that lymph node, get to that lung nodule. Navigational bronchoscopy essentially is a way of mapping your airway so that you are close into the vicinity of that lung nodule, and you can biopsy it. It is, so to speak, in a way, a GPS. The technology has improved over the last 5 to 7 years, and we have very specific directions to how to get to the smaller and smaller, the primary, the secondary segmental bronchi, so that we can get to that lymph node. So I believe that navigational bronchoscopy is an extension of regular bronchoscopy, but it is an added advantage that you have a GPS that maps you through and takes you to the exact location of the lymph node. Now, why wouldn't we be able to get to that lymph node? For example, if the lymph node is too far away from your chest wall, so you can't get to it through the percutaneous biopsy. You have no other lymph node to biopsy, for example. And these lymph nodes and navigational bronchoscopy has shown very promising results in the last 5 to 7 years. It has been around for a while, but with the improvement in technology, I think the outcomes and the yields have been much improved. Next slide, please. Another case, I'm trying to put everything that I talk about into clinical context, and that's why I started with cases. This is an 85-year-old male. This was actually my patient in the ICU. I had to come in at 8 o'clock at night to see this guy. 85-year-old, presents to the ER, acute shortness of breath, pleuritic, chest pain on the left. He said he was watching TV, he was eating grapes. He was edentulous, but still decided to eat whole grapes and choked on one of it and started with this pain. He was describing the pain as very pleuritic on his left side. He couldn't breathe. He was gray and ashen, but able to talk to me in the ER. He was on a non-rebreather mask, saturating anywhere between 78 to 80%. Next. So this was his x-ray. This was his x-ray when I was sitting in the ER looking through his chart and talking to him and his wife and his daughter. This was the x-ray that we saw. He had complete whiteout of the left side with mediastinum and everything kind of shifted towards the left side. So we knew that this was something which was obstructing his airway, hence atelectasis, pulling everything towards itself as compared to, for example, a large effusion. Next. This was the grape that we pulled out of him. We did intubate him for this procedure, specifically because he was hemodynamically unstable. We had to intubate, and we fished out this grape out of his airway. Next slide. Bronchoscopy for foreign body retrieval. Again, this has become, in last 10, 12 years, this has become a part of regular pulmonary practice, is using these retrieval methods, whether that is a basket as shown here, and here's a endobronchial, what looks like a stone that is being retrieved out of the airway. Here's the forceps biopsy. We can use different modalities to fish out foreign bodies out of the airway. Forceps is one of them. Basket is the other. Cryo, which is a probe that is used to freeze tissue to remove the foreign body, is the other. Next slide, please. So cryoprobe can be used for foreign body retrievals. The reason I have a specific slide on cryoprobe is because that's what we used in our patient to retrieve that grape out. If you can, as you can imagine, any foreign body that has a lot of water content tends to stick to the probe when you freeze it. And it is also used for endobronchial tumor debulking. Next. This is what the probe looks like. This is the tip of the probe. It's a metal tip that freezes. And we usually touch the tissue with the tip and freeze it for anywhere between 10 to 20 to 30 seconds, depending on what the indication is. Next. Next. This is an airway where there was an endobronchial tumor. It is a melanoma. This is not one of my patients. This was a picture I took out from internet that showed pre-cryo and post-cryo airway. And the results were pretty significant. And we have seen here that we have had some patients where endobronchial tumor debulking was done using cryo. Next. I have another picture from one of my patients. This was me in the ICU last week. We had a guy who came in with ARDS. He had a tube exchange done by anesthesia on Wednesday. Started having hemoptysis, as you can see in the background, his ET tube and the tubings were full of blood. We decided to go in and take a look to see if he was having any active diffuse alveolar hemorrhage, bronchial bleed, or bleeding from the upper airway. We went into his right main stem, which was open, but the right bronchus intermedius, which is the lower lobe and the middle lobe takeoff, they were blocked off, and this is the clot that we fished out. Here's my bronchoscope, and here's the cryo probe that is coming out through it. We went into the clot. I froze it for 10 seconds. It thawed immediately, so I had to freeze it for 20. Again, depends on what you're treating. The duration of the freezing is decided based on that, and we were able to remove this whole cast of right lower lobe basilar segments from his airway. Next slide, please. So the next case for, what are we dealing with when we talk about interventional pulmonology? This is a 32-year-old guy, short of breath, dyspnea on exertion. He has been reporting weight loss for last 2 months, 20 pounds, intermittent fevers, chills, some hemoptysis. CT and bronchoscopy images are shown. Next. This is his bronchoscopy image. This is in the main trachea, and this is his CT image, where you see that the trachea that is supposed to be 2.5 centimeters or 3 centimeters in a male patient is very compromised. So there is critical narrowing of the airway. Next. And this is what we're going to talk about next, which is airway stenting. So airway stents have been around for a while now, and they used to be purely rigid bronchoscopy was used as a method of deploying airway stents. However, in last century, 21st century, we have seen tremendous improvement where we use flexible bronchoscope and we are able to go in and stent an airway. However, as a physician, we do like to make sure that we are stenting for the right indication, for something that we think will relieve something and improve something, whether that's quality of life, pulmonary function, or symptom reliefs. And choosing the right kind of stent, again, is a decision one has to make based on case-by-case basis. Next slide. I have to mention Dr. Dumont here. He's the French physician credited with modernizing rigid bronchoscopy and coming up with Dumont stents. They are silicone-covered stents, and at present they are being used to stent airways. The shape of the stent, if you will, depends on where exactly in the airway are we planning to stent. So based on the anatomy and the shape of the airway, the shape of the stents can be, so to speak, tailored, and you can order a stent based on what shape airway you're going to stent. Next slide. Next case would be a 65-year-old male, ex-smoker, 100 back years, known history of COPD, FEV1 of 34%. He's on maximal therapy. He's on LAMA, LABA, even ICS. He's on Daliresp. Exacerbations are not uncontrolled. They're actually quite controlled. However, he continues to have severe dyspnea on exertion. Next. And this is his chest x-ray, which essentially shows his hyperinflated lungs. There is definitely upper lung zones that have less blood vessel markings and lung markings. That tells us that he does have heterogeneous emphysema. And that's kind of the key word here, before we go to our next IP intervention. That is heterogeneous emphysema in a patient who has severe COPD. Next, please. This is the CT scan image that shows hyperemia in the upper lobes, bilateral. Next, please. So endobronchial valves, that is something that I think most of my patients that watch television do come in and ask me about. You know, hey doc, I was looking at TV and there was this ad about these valves that people are getting put into their lungs. So what are these valves? Essentially, endobronchial valves are one-way valves that have been looked at in heterogeneous emphysema in patients with severe COPD. Emphysema specifically is debilitating in patients because one, their FEV1 is low. Second, because of hyperinflation, the diaphragm is so compromised that it is unable to participate in their breathing process as much as it would if they did not have hyperinflation. Currently, we know that lung volume reduction surgery is one way of reducing emphysema, but a minimally invasive way of doing a lung volume reduction is what is the bronchoscopic lung volume reduction, where you deploy the one-way valves. Next, please. So bronchoscopic valves are unidirectional. What we have to do as physicians, as pulmonologists, is one, evaluate the patient, see if they have severe disease, CT scan them and see if they have heterogeneous emphysema. So they cannot have diffuse emphysema in the lower lobes, middle lobes, upper lobes. In that case, the valves don't tend to work as well. If they have, say, upper lobe predominant emphysema and they're not surgical candidates for lung volume reduction, this is a good alternative. The aim is to occlude the airway that is going towards the emphysematous lung. The valve, the way it works, if you could hit next, Caitlin, I have the picture of the valve. The way the valve works is here. When you breathe in, the valve closes, it doesn't let the air in. But every time you breathe out, it lets the air out. So it is a unidirectional valve that works to so to speak, to deflate that area of hyperinflation. There are very specific criteria. For example, when we decide to select a patient for this procedure, we have to make sure that the patient is not someone who has recurrent exacerbations and can go through the procedure safely. When we go in to deploy a valve, you have to make sure there is no collateral ventilation, because lung is like a, so to speak in colloquial terms, like a sponge. It does have collateral ventilation. So if you block one of the bronchi going to the lobes, but if it has collateral ventilation, you're not going to be able to achieve any results. Next, please. I have a CT image of the same patient we talked about that had the upper lobe predominant emphysema, had endobronchial valve placement, and that led to, so to speak, an atelectasis, an iatrogenic atelectasis of the left upper lobe, causing him to have less hyperinflation on the left, better diaphragm positioning, and decrease in shortness of breath, that's subjective shortness of breath, and improvement in exercise tolerance. These are the two big things that we have seen. There are a few cases that were reported of focal emphysema that were treated with the valve, and the patient actually had significant improvement in PFTs. One of the other indications for these endobronchial valves is if you have a bronchopleural fistula. If someone has persistent pneumothorax because of a bronchopleural fistula, these valves have been used in those patients too. Next, please. The next case is, we are heading towards the end of my talk, I promise. A 23-year-old female, known severe persistent asthma. She's on maximal therapy. ICS would be inhaled corticosteroid, LABA, LAMA, oral steroids. She has still continues to have uncontrolled symptoms in terms of she continues to have dyspnea on exertion, limited quality of life. Being a 23-year-old, it's quite hard. Next, please. So bronchial thermoplasty is another procedure that has been looked at. Actually, the initial study that came up with the concept of bronchial thermoplasty did not have a significantly positive outcome. So we have had multiple discussions in journal clubs about bronchial thermoplasty. What it is essentially is, when you think about airway in asthma, it is the airway smooth muscle, or the ASM, that hypertrophies over the years. And some of these patients have more hypertrophied muscle than the other. And it is these patients that tend to respond better to bronchial thermoplasty. The key is, it needs to be a patient who has exhausted every other non-invasive modalities for treating asthma and has failed. And the recommendation that we give to our patients, we do not do this procedure here at WVU, but the recommendation that we give to our patients is that we would like them to see a center where they do the bronchial thermoplasty in a big number, and we refer them. But the prerequisite being that they do have exhausted most of the other non-invasive modalities. It is a radiofrequency thermal energy that is used. I think in my next slide I have the picture of how it is done. Next, please. This is just the picture demonstrating the healthy airway in a patient, in a regular adult. This is the airway in a patient with asthma, where you do see more mucus and hypertrophied muscles, excess airway smooth muscle. And this is when they have an acute exacerbation. The muscle causes worse bronchoconstriction. Obviously, they have airway edema. And after bronchial thermoplasty, what we do is we try to burn this muscle off. So instead of being fleshy, muscular, causing severe bronchoconstriction, it tends to be less fleshier. And the bronchoconstriction, when they go through an exacerbation, is not as bad. Next slide, please. This is how it's done. It's again done with a flexible bronchoscope. It was approved by FDA in 2010. Once the bronchoscope is in the airway, it is done in 3 different sessions, so 3 different bronchoscopies that are spaced out by a couple of weeks. We usually do right side first, so right lower lobe, then right upper lobe in the second session, and then left lower lobe in the next session. Right middle lobe is usually spared because the airway leading to the right middle lobe is small. Through the working channel, something what looks like a basket, but it has thermal probes here, and a basket comes out. We touch it to the airway and turn on the radio frequency, and it generates thermal energy and hence burns down the mucosa and the muscle. Now, you could imagine if someone has bad asthma and is in an exacerbation, this can actually make them worse. So it needs to be an asthmatic who is stable at the time of bronchoscopy. And obviously, there have been instances where people have gone into an asthma exacerbation because they went through this invasive procedure. That's why I believe the data to support bronchial thermoplasty in asthmatics is limited, and the patient selection is the key here. Next, please. The last slide is essentially a quick recap of what we do here at WVU. We do EBUS TBNAs and NAV bronchs almost weekly. EBUS TBNA is more, so we do multiple per week. Navigational bronchoscopies, I think we have picked up and done much more in last 1 to 1.5 years. Cryo, basket, and forcep is a standard part of our pulmonary fellowship practice, and all the fellows are trained in doing the foreign body removal. However, doing the tumor debulking is something that we do rarely. Thoracic surgery here at WVU and does the airway stenting. They do the rigid bronchoscopy with the airway stenting and the flexible bronchoscopy with airway stenting. We are still debating about the endobronchial valves and if we can start doing those here at WVU. And currently for bronchial thermoplasty, what we do is we refer our severe asthmatics to UPMC. Dr. Sally Wenzel at UPMC sees most of them. And if deemed fit, some of them have gone through bronchial thermoplasty. I think that is my last slide. Thank you. I know I went on and I'm happy to answer any questions if there are.
Thank you. That was wonderful. We really appreciate it. Let's see. To start it out, we did have one question asked to be held till the end. Can you explain the terminology of station like 4 or 10 or 11 or etc.?
So it's an anatomical designation. So station 4, for example, right around the trachea, towards the lower end of the trachea is where the station 4 lymph nodes are. Station 7 is the subcarinal lymph node, the lymph node that sits right at the carina. Then we can go to station 10, that is we are going to the right main stem, and the station 10 nodes are at the hilum. And then station 11 are at the subsegmental bronchi. So that's how they're essentially anatomically numbered, so to speak.
Perfect. Thank you so much. Guys, you can feel free to unmute yourself and ask Dr. Zulfikar questions. You're also welcome to chat them in and I'll ask them.
I'll ask a question. What's the best way to get a patient onto your schedule if we need them to have one of these procedures done?
So one of the quickest ways is to see if they can, for example, EBUS is one of the big reasons why we get referrals. And if it's a patient where we're suspecting malignancy, the quickest way to get them in is to get them into the cancer clinic. We do Tuesday cancer clinics, and usually we are able to get them in and get them scheduled pretty quickly. If it is, for example, for anything else, well, we don't do the valves or the thermoplasty here, but for stenting, usually we contact the physicians and see if they can fit them into the schedules, and thoracic surgery is pretty good with that.
Is the cancer clinic still the best way to get them into the thoracic surgeons as well?
Yes,
okay.
Because on Tuesdays, it's the medical oncology, us, and thoracic surgery. Yeah. We see them together, yeah.
Thank you.
All right.
All right, guys. And if you have any other questions, please feel free to email them and I'll make sure Dr. Zulfikar gets them. Again, Rafia, we are so appreciative of you being
here. Thank you so much for letting me start and you know, for accommodating the request. Thank you so much. You all have a wonderful day. I won't be able to stay for the rest of the conference, but
Absolutely.
Hopefully I'll join in the next one.
Perfect. Thank you so much.
Thank you. Bye-bye.
Bye. All right, guys. I wanted to see Lisa. Are you good to do your presentation? Yes. Yay. All right. I'm going to share that and we can go through it.
I don't know how I'm going to follow that. That was fabulous.
All right. Whenever you're ready. It just got real loud here, so I'm going to mute myself.
Okay. This is a 50-year-old female who will be starting pulmonary rehab this week here at New River. She is, I guess, I'm not quite sure where you guys want me to go with this. You can see, you know, her breath sounds and her respiratory meds. She's on oxygen, 2 liters continuous. You know, when she's out and about, she does use the on-demand flow. Go ahead and keep going. Never a smoker, and she has severe bronchiectasis. She has restrictive lung disease, and she's O2 dependent. She had been seeing a pulmonologist here in Beckley, and they had referred her to WVU, which I wanted to get her with Dr. Zulfikar right away, right? So she's very symptomatic, and she feels like she is declining every day. Her forced vital capacity post-bronchodilator is 53%, 1.77. Her FEV1 is 57%. Her actual is 1.50 post-bronchodilator, and her actual ratio post-bronchodilator is 85. So she's restrictive. Her lung volumes suggest true restriction. Her diffusing capacity is 43%. And she is a pretty, just a desperate young woman wanting to know what's happening. She used the test, does not feel like it's, that is very effective to her. So kind of what happened was about 13, 14 years ago, she came down with a severe case of pneumonia, and she does test positive for all kinds of yucky things. Let me grab her labs. Klebsiella pneumonia, MRSA, and Pseudomonas growing in her lungs. And so she is just now being tested, and the results are not in. She's not going to be tested until March the 11th in Morgantown. She's going to have a sweat test to test for cystic fibrosis, and the results are not in on her alpha-1 antitrypsin test. So she will be bringing me, this may be a case that we revisit whenever we're able to get actual visuals of her CT scan and the results of these tests. So the main questions are, what are the likely etiologies for her left side bronchiectasis? How likely is it that the bronchiectasis accounts for the severity of her obstruction? And what are the additional treatment options for her? Period. Any other suggestions from the pulmonologists out there on further testing to do, or different ways to handle her in pulmonary rehab, I guess?
Has she had an echocardiogram?
Let me look in here. I know she had a stress test.
This is Dan on the telephone. And I just wanted to say that we do have, and I have an echo on my phone, that's why I'm talking slowly, but we do have both chest x-ray and CT scan narrative on her. Her chest x-ray, January 23rd, 2019, showed chronic lung changes without evidence for acute cardiopulmonary process. So not much. And then we have a CT scan, more recent. And just take a look here. This was in November. It says extensive left-sided bronchiectasis with left lung volume loss and underlying coarse reticulonodularity. Overall, no change since May 30th, 2019. And I'm in her record, and we do have an echocardiogram. And this was in March 2019. And it showed left ventricular systolic dysfunction with ejection fraction of 46%. So that's not a lot of systolic dysfunction. Mild pulmonary hypertension with a calculated RV systolic pressure of 39, and everything else is normal. So this is a potentially normal echocardiogram, except for the pulmonary hypertension, which is frequently a false positive, but prior probability is that she would have pulmonary hypertension, so it's probably true in this case. Does that help you, Allison?
Yes, I was trying to figure out why her diffusion capacity would be so low. I mean, if she's got extensive bronchiectasis, you know, anything that's going to affect the barrier where the lungs exchange oxygen and carbon dioxide, and the blood-air barrier is going to affect their diffusion capacity. So if you've got destruction to the lung tissue, it's not exchanging normally at that area. So that can decrease your diffusion capacity. But if it's isolated to one area of the lung or one lung, I was wondering if there was something else that might be lowering that. And pulmonary hypertension can also cause that diffusion capacity to be lowered. So that may explain part of why her diffusion capacity is as low as it is, with her pulmonary function tests looking the way that they do.
Yeah, and that was kind of my question when Lisa had me originally evaluate her for pulmonary rehab. And the question I listed at the end of the case, does the bronchiectasis explain all her, oxygen transfer dysfunction, or is there another disease process going on here? And we do have another pulmonologist on this call, Drew Harris from UVA. If you're still there, I'm really excited you're with us today. Any comment?
I think he may have dropped off, unfortunately.
Okay, I lost my participant's view here for a minute. Too bad.
Do you
So
guys?
Allison, back to you. What should we do next?
How symptomatic is she with her bronchiectasis? Does she have frequent exacerbations or flare-ups?
I'm just getting to know her. She is constantly coughing the whole time you're speaking with her, whether it's over the phone or in person. As far as her exacerbations, I think right now this is just an ongoing thing for her. She's, purulent, thick sputum. She, like I said, she doesn't feel like her vest is doing her much good, but I just continue to encourage her to use it. Better use it than not to use it. She's just a really sick young woman. As far as in and out of the hospital, I think she's not in and out of the hospital.
Allison, other than a lot of purulent sputum production all the time, which is kind of baseline, what would an exacerbation of bronchiectasis look like?
Usually I see frequent infections where people end up on antibiotics all the time. And one of the things that I've used in some of my patients that were always coming in for antibiotics is you can use a azithromycin 3 times a week, like a Monday, Wednesday, Friday dose, to sort of, it's not necessarily the antibiotic effect that you're getting, but it's more of the anti-inflammatory effect that you're getting. That helps to decrease any sort of inflammation, which may actually help her if she's got some inflammation in those abnormal airways. So that might be something that they might want to consider. I'm sure WVU is probably waiting, though, to get the sweat chloride test back to see if she's got cystic fibrosis and the alpha-1 antitrypsin, because there are special treatments that are needed. I'm so sorry. Or special treatments that are needed for both of those diseases.
I'll take that baby, Allison.
She's
I'm not sure if I should ask you another question right now, Allison, or not.
Go ahead. Go ahead.
Well, we've also seen aerosolized antibiotics in bronchiectasis. Where do you stand with that?
I've never really had good luck with that. I don't know that they do a whole lot of good for bronchiectasis. I do see them more often used in cystic fibrosis. So.
Okay.
Most of the time, like I said, you're not necessarily treating the infection in bronchiectasis on a day-to-day basis. What you're treating with the azithromycin is the inflammation. And it works a similar way in our COPD patients, that it helps to treat the inflammation that they have in their lungs versus being a true antibiotic for them. And it's usually 250 milligrams given every Monday, Wednesday, and Friday.
Okay. Brandy and Dean, and Sam, you're our respiratory therapists out there. Have you guys seen cases like this? And what's happened?
My input, Lisa, would be, is she on a vest? Does she use a vest at home?
Yes, she uses a vest every day. She says that she doesn't really see the difference. I'm trying to explain to her that it's, going to keep her from having exacerbations, so that she continues to be able to cough up the sputum. I was curious myself about inhaled antibiotics, but I guess we'll wait and see what the sweat chloride test comes up with as far as that goes. I'm just basically, she definitely is down on life and sees a psychologist, really depressed, and kind of, she says she just lives for her daughter, but I'm here to just really encourage her and have her not to get frustrated with all these doctor's appointments that she's going to, and let her know that they've got to do the research first and then help her out. So stick with it.
Yeah, just keep encouraging her to be compliant and not give up, and maybe she can get some answers and some relief to her symptoms now that she's seeing some different specialists.
Right. And like I said, she is really excited to start pulmonary rehab. She feels like every day she declines. So, yeah. So like I said, I would actually like to revisit this case eventually to come back with all her test results.
Yeah, I think that would be good, Lisa.
Hi, this is this is Sam. To answer your question, Dan, you know, I'm a respiratory therapist, but you know, the last time I practiced, you know, it was in the dark ages. But I'll tell you, it's a psychology issue. I think her depression is driving the bus on a lot of things here. I guess I would ask, how active is she in terms of physical activity? I think the more she could be physically active, the better effect she's going to get from the vest. And also, she should look for, or perhaps you've already done this, metrics that where she could hang her hat on. She's made some progress. If she could move around. I'm so happy to hear that she is going to begin pulmonary rehabilitation, but I think she needs to up her activity to the extent she can, and also, even though it's kind of a not an appetizing thing, to look at what she's the amount of mucus she's coughing up. If she's coughing up a lot, she should be encouraged rather than discouraged that she's congesting, because she'll know then that she's doing something to help her health status. And that's where activity could play a role as well, because we know that more active patients find it a bit easier to cough things up and to clear her lungs. The other side of that, of course, is I don't know how much liquid she drinks and things like that, but hopefully she's taking in tons of fluid and trying to thin the mucus to the extent possible. But I'm so happy to hear she's going to join the rehab program, and I know that you'll be educating her on those things. I think she needs some milestones that she could measure herself and her progress against on at least a weekly basis, if not a daily basis. Does she have a pulse oximeter?
She does, and I think that these milestones that you're talking about are going to be easy. You know, for someone who can't even carry her groceries in, and being 50 years old, I'm really hoping that pulmonary rehab will get her those baby steps that she's looking for. The water situation, I've always seen her with a bottle of water, so I know she's drinking water. Yeah, I think it's kind of going to be tackling this depression. And, you know, one of the goals that we talked about mentally for her is she feels that this is going to give her hope. So we just got to, you know, keep encouraging her.
Absolutely. And I know we in the medical side, you know, we understand the mental aspects of chronic disease and the discouragement. But I just think that goals and the achievement of goals, even if they're baby steps, do help with their mental capacity to be encouraged to continue to follow your regimes as you order them and instruct her, but also to make sure in between she's not just sitting around moping around, because that's only going to make things worse.
I wanted to point out too that Brandy offered a piece of advice in the chat that peak flow meters at home and muscle trainers at home can be good places to start, which is great.
Well, I don't know if you, yeah, I guess you can hear me. I just wanted to acknowledge several people with us today who have been really very faithful participants. Eric Stockton with Dorney Koppel, Diana Carpenter from the Pennsylvania Rural Health Model. Hi, Diana. And Krista Mistel from the Federal Office of Rural Health Policy, who's with us almost every time. And last, but by no means least, it's great to see that you're with us, Grace Ann. You want to say hello at all?
There might be a problem with the mic, but that's okay.
Guys, I've got to run off to pulmonary rehab, but thank you for your input. Since she is starting this week, it's actually fun to do a case on someone that hasn't started pulmonary rehab so that I can come to the table, you know, with more encouragement and hope for her. So thank you guys.
Absolutely. And thank you so much for presenting. We are obviously happy to hear a follow-up, and I'll make it as easy as possible, I promise.
No worries. Thank you. Always make it easy. I appreciate you guys.
Thanks, Lisa. I know that you were bombed this week, and you've been here anyway, and you did a great job. Thank you.
Thanks, Dr. Doyle. Bye, guys.
Bye. So guys, I guess we can call it there. I do want to remind everybody our next session is going to be on the 16th. Dr. David Weissman is going to give us the didactic that day. He's going to talk about, let's see, natural gas production and lung health. I don't really know what that means, but I'm sure you guys do, so that's wonderful. If you guys have any cases or anything, let me know and I'll help you with those. And everybody have a wonderful week.
Thank you.
Thank you, Caitlin. Bye, everybody.
Bye.